L'encombrement du service des urgences pose problème depuis plusieurs années. Un projet pour le roulement des patients fondé sur la rémunération au rendement a été lancé dans des hôpitaux comme l'hôpital général de Vancouver afin de fournir aux patients des soins dans de meilleurs délais, d'améliorer l'accès au diagnostic et d'accroître la capacité d'admission des patients. Mais en quoi consiste la rémunération au rendement?
Pay for performance is an incentive-based funding model that allows healthcare professionals to come up with innovative, creative strategies to deliver service to provide better health outcomes.
Well, actually, the name is a bit misleading, to be honest with you. People expect that what we're doing is paying nurses and doctors to work faster and harder, and nothing could be farther from the truth. First of all, we're not paying any individuals. Nobody gets any more money.
The Pay for Performance initiatives was really based on ideas that germinated in the emergency department. The ED groups got together and decided amongst themselves what changes would be helpful.
The demand always outstrips our capacity. So even with P for P and what it has provided, it still requires us to keep doing things differently.
When you walked into the emergency room and you thought, you looked around, what you felt was you felt a very sort of frustrated group of clinicians that weren't feeling good about what they were doing.
We really began to suffer from what we call access block and ED overcrowding. Before we started, the average length of stay for admitted patients was 15-16 hours. And after we implemented the P for P, we dropped it probably by 15 or 20%.
There's an impression out there among the lay public that what we're doing is cramming people through faster. But that's not the case, because there are only so many things you can do to a trip through emergency to a patient. You can't really change that much in how they're cared for. They take a certain amount of time, doctor's assessment, tests, whatever, they're going to get treatments.
What the financial incentive does is give you a little bit of comfort in taking risks that you might not otherwise have taken. So if you're working within a system that has a fixed funding envelope, you tend to stick with what you know you can safely fund and safely do to deliver service. If you have a little bit of an incentive to try different things in order to create more access, financially, you'll take risks and try different things.
What we're trying to do is give the staff some power and authority and some money to make some changes that they think they should do in their own institution. So we're really empowering the staff at the ground level, if you like, at the patient interface, to make the improvements that they see they can make in their own institution.
Now we have a strategy where nurses on all of the units are aware that we have this funding, and so they really work hard on a daily basis to try and get their patient out in order to try and get that patient up and onto their inpatient unit.
Le financement par rémunération au rendement donne à l'hôpital plus de choix en matière de personnel, d'outils de roulement des patients et d'autres initiatives. Les patients peuvent aussi réduire les attentes quand ils ont besoin de soins urgents en consultant en ligne le tableau de bord des temps d'attente aux urgences. Il indique l'hôpital où les délais d'attente aux urgences sont les plus courts.
The dashboard is another tool. It's a tool designed to affect the input of what comes into the emergency department. So pay for performance really affects the throughput and output side of the equation. And the input side is something that we're trying to tackle with this, trying to get people to help by looking at the departments and seeing which is perhaps less busy and going to maybe a less busy emergency department.
We've introduced and invested in a capacity planning tool, and that tool allows us to predict for the next week or so what our demand will be, how many patients are going to come in, how many patients we're going to be able to move out.
So that information is available to a lot of people that before it was always kind of a one-to-one conversation, you know, I would tell somebody else. This way it's all captured in one place.
The P for P project and focus allowed us to identify where the barriers were to patient flow and then do something about it. We know that a busy emergency department, a full emergency department, kind of equals to very stressed out staff. So When staff morale improves, when staff feel happier about their work, we're obviously achieving some good results in patient flow as well.
We've almost eliminated all of the cases waiting greater than a year. We had about 1,400 cases waiting greater than a year. These are patients, these are real people that have been waiting for surgery for 1, 2, 3 years. We're down to about 300 from 1,400, and we're marching towards zero.
There's a lot of ways that pay for performance can work, and there's a lot of ways that it can go sideways, but the two key ingredients are total support from leadership and participation at the grassroots level.
I think it's a much better model than just feeding money into the fixed budget part of the system, because it is performance-based and it's outcome-based.
Getting patients moved out of the department more rapidly allowed us to deal with those ill and injured patients that were coming through the front door. So rather than seeing them outside or in the waiting room, we were able to see more of them in the, if you will, appropriately staffed stretcher spaces.
Once the staff felt that, yeah, actually things are better, then I couldn't stop it. Once you give people, the staff, a taste of real success and the ability to actually do their job the way they should, they won't let go.